Welcome to today's case discussion number 1 on acute cholecystitis. This is a clinical summary of the patient. He's a 67-year-old fisherman who presents with a sudden onset of severe right hypochondrial pain for 5 days. It was localized to the right upper quadrant with no radiation elsewhere. It was associated with nausea and vomiting for the last 2 days, and he admits having similar but milder pain off and on 2 occasions before, for which he took some painkillers to relieve the pain. There's no history of fever, no diarrhea, and no urinary symptoms. He is a diabetic for the last 10 years and on treatment. On examination, he is afebrile with no pallor or jaundice. There is tenderness and guarding in the right upper quadrant, and Murphy sign is negative. The liver and spleen were not palpable, and rest of the abdomen is normal. Now we come to the analysis of the symptoms and signs in the patient. Okay, these are the symptoms: severe right upper quadrant pain for 5 days. He's an elderly man, 67 years old, associated with vomiting and similar episodes twice in the last 2 months. He's a diabetic. Examination: there's tenderness in the right upper quadrant with guarding, Murphy sign negative, and he is afebrile. So with these clinical symptoms and signs, the provisional diagnosis would be acute cholecystitis due to gallstone. The differential diagnosis would be acute gastritis, perforated peptic ulcer, acute pancreatitis, and cholelithiasis with cholangitis. Okay. This slide shows you the symptoms of a gallstone attack. Pain in the right upper quadrant of the abdomen, pain radiating to below the right shoulder, nausea and vomiting, and pain between the shoulder blades. So in the evaluation of this patient, we look into the history, the physical examination, some blood tests, ultrasound, and other imaging as needed. Okay. As for the physical sign, it is very important to elicit or check for the Murphy sign. How do we do it? These diagrams in the pictures here will show you the number of ways of eliciting the Murphy sign. But the most commonly used, the one with the palpating with your right palm. While applying pressure in the right upper quadrant, as shown here, ask the patient to inspire, to take a deep breath. Murphy sign is positive when there is a halt in inspiration due to pain, indicating an inflamed gallbladder. This can be achieved more accurately with an ultrasound, and that is known as a sonographic Murphy sign. Now, the investigations for these patients include blood tests, urine, imaging, and biopsy, special tests for the patient, and others may be necessary. Okay. In the blood investigations, important things to be done are the full blood count, the renal profile, liver function, and other tests. Okay, under the full blood count, the most important is your total white count, which is elevated. Under the renal function test, all the results are normal, and liver function test is essentially normal except for elevated aspartate aminase, okay, which is elevated. The blood glucose is also elevated, greatly elevated to 27 millimoles per liter. And it is important to do the blood culture and sensitivity on admission. Okay, these are all showing the elevated parameters. So the imaging methods used for the investigating this patient will be a plain X-ray, which consists of a chest and abdominal X-ray, ultrasound scan of the abdomen, a computerized tomogram or CT scan of the abdomen, magnetic resonance imaging MRI if it is necessary, and endoscopic retrograde cholangiopancreatography or ERCP if there's evidence of bile duct obstruction. Okay, this is a normal X-ray of the abdomen showing you the bowel shadows. Okay, these are the large intestine. The small intestine is not distended. There are some shadows in the middle. So this is a normal abdominal X-ray of the abdomen. And this is a normal chest X-ray. So it is important for patients having severe upper abdominal pain to do these two investigations to rule out pathologies related that can be identified in these X-rays. Okay, so some of the things that can be excluded will be elevated right diaphragm, which is a feature of a liver abscess, consolidation of the right lower lobe or right lower pneumonia, and free air or right pneumoperitoneum air under the diaphragm, which shows a perforated peptic ulcer. As for the ultrasound, okay, this is a normal gallbladder with a thin wall and empty lumen. The wall is thin, the lumen is empty. The length is around 7 to 10 centimeters in length and 3 to 4 centimeters in transverse diameter. The thickness of the wall should be less than 2 millimeters in thickness. Okay, and this is a ultrasound to show you the gallbladder. Okay, here this is the portal vein and this is the extrahepatic bile ducts. Okay, and this is a ultrasound picture of a gallbladder showing gallstones. Okay, this is a gallbladder. The wall is thickened. Okay, and multiple gallstones seen within the lumen, and these are identified as gallstones by the posterior shadow they cast on ultrasound. Okay, this is a normal gallbladder again, ultrasound picture with gallstone and acute inflammation changes. These inflammation changes, thickened gallbladder wall should not be more than 3 millimeters in thickness. You get a pericholecystic fluid here, okay, pericholecystic fluid and a wall that is thickened and multiple stones casting posterior shadows. So these three are the features suggesting gallbladder contains stones and the gallbladder is inflamed. Okay, this is another few pictures to show you the ultrasound of the gallbladder. There's a stone here, but the gallbladder wall is not thickened and no evidence of pericholecystic fluid. So this is either an asymptomatic gallbladder, gallstone, or biliary colic. This one, a gallbladder with multiple stones casting posterior shadow here. So this is a normal gallbladder, a gallbladder with a stone in the neck of the gallbladder. CT scans at times may be necessary in cases like this, where it shows the gallbladder here, which looks quite normal. Whereas here, the gallbladder is dilated, thickened with the stones in the neck of the gallbladder. Okay, what are the complications of acute cholecystitis? First, empyema of the gallbladder, where the formation of pus within the gallbladder due to cystic duct obstruction or gallbladder outlet obstructions at the Hartmann's pouch. Perforation of the gallbladder with bile peritonitis is another serious complication of acute cholecystitis. Sepsis and septicemia related to empyema of the gallbladder, and repeated attacks leading to chronic cholecystitis. Now we come to the management of gallstone cholecystitis. Okay, first confirm the diagnosis, and this can be done by ultrasound of the abdomen. Then continue with initial treatment or resuscitations with IV fluids, electrolytes, antibiotics, analgesics, and if the patient shows signs of septicemia or infection, which is not there in this patient, you may have to admit the patient with ICU and give oxygen. In the process, you do a close monitoring of the patient, BP, blood pressure, pulse rate, and oxygen saturation, and urine output. When the patient is stabilized with all these initial treatment, then you proceed with the definitive treatment. So in this case, first is medical treatment, which consists of analgesics and antibiotics. And the antibiotics normally given for these conditions, gallstone acute cholecystitis, will be cephalosporin with or plus or minus metronidazole. Then endoscopic treatment can be done, especially if there's a stone in the bile duct. Then a endoscopic sphincterotomy may be needed. In this patient, that is not necessary. So we go on to surgery. Okay, so these patients need surgery. They need cholecystectomy, which can be either open or laparoscopic. Okay, so here summary of the treatment: initially conservative, followed by cholecystectomy. So these are all the conservative treatment. Cholecystectomy preferably done within the first 2 days if necessary. If the patient shows signs of worsening or signs of infection, sepsis, or if the patient improves, then antibiotics is continued until the patient recovers fully, and elective cholecystectomy will be done after 6 weeks. So initially conservative treatment followed by elective cholecystectomy is the treatment of choice. Unless the patient becomes more ill within the first 2 to 3 days, then an emergency cholecystectomy may have to be done. Okay, these are some questions to be answered. Whose sign is elicited on examination of the abdomen? The answer is Murphy sign. What is the most likely diagnosis in this patient? Acute biliary colic or acute cholecystitis due to gallstones. What is your first line treatment for this patient? IV fluid, analgesics, antibiotics, followed by surgery, which is cholecystectomy. What would you prescribe to treat the high blood glucose in this patient? I would give him IV insulin titration against the blood sugar. And question number 5. What specific complications in this patient is this patient at risk of? Empyema of the gallbladder, gangrene, perforation, and septicemia. Thank you for your patience, and I hope to see you again in a similar session in the near future. Thank you.